welcome everyone. We're very excited to be partnering with the Lancet Commission and the World Psychiatric Association to host this African launch of the Lancet Commission report on depression. I think that many of you might know that this institute that's hosting this event, the Brain and Mind Institute, is a fairly young institute that has been a couple of years old. And it's been created to really fill one of the gaps that we perceive that exists in East Africa in particular, to deal with mental health and neuroscience issues. So if I may share my slides. This is our logo that shows the connectivity within the brain, but it also talks about connectivity within our community members and our partners. And you can see the leaf that indicates a growth mindset. So when I went to school, I was told that the brain is not very plastic. Now we know very differently about the brain, and it's very exciting. The institute is associated with the Aga Khan University that has a global footprint. And the Brain and Mind Institute has a hub in Nairobi that serves East Africa and a hub in Karachi that serves South and Central Asia. Our vision is healthy brain, healthy world. And our mission is to advance research, educate, to do collaborative approaches to research, education, and innovation. And our values are congruent with that of the university: impact, quality, relevance, and access. The institute itself operates on 4 pillars. One is research, the other one is innovation and translation, third is education, and the fourth is engagement. So our primary focus as it comes to mental illness is on depression and anxiety, and hence highly relevant to today's discussion, but also on stress and trauma and suicide prevention research, which are all sort of interconnected areas of work. One of the things that we're pushing hard through the Brain and Mind Institute is the model of stepped care that has been promoted by the World Health Organization, where instead of focusing primarily on severe and moderate illnesses, we're suggesting that we focus a lot more on well population, people at risk, or people who are mildly ill, mainly because the capacity of psychiatrists and psychologists in our countries where we serve in Africa are very limited, and we need to mobilize the resources that are most available. And we are having some very exciting discoveries of how even a low level of intervention has such a large impact on well-being for mental well-being. And finally, I'll just say that our DNA is of collaboration and working together with partners across the world. And it keeps with the adage of that if you want to go fast, you can go alone, but if you want to go far, we go together. And that is precisely our motto. So without further ado, you know a little bit about the Brain and Mind Institute. Now let me introduce you to Dr. Lukoy Atwali. Dean Atwali, he's the Dean of College of Medicine in East Africa at the Aga Khan University. He's a professor of psychiatry, of course. He's a psychiatrist. He's a leader in the field. He's a prolific researcher and really a transformative teacher. Dean Atwali is also the associate director of the Brain and Mind Institute, of which we're very proud. So he's a true friend and colleague. And with that, I'll pass it over to Lukoy.
Thank you very much, Zul, for the very kind introduction. It's my pleasure now to welcome everybody to this webinar and to introduce our panelists for the day. We have assembled a stellar cast, if I must say so myself, of panelists who are coming from across the African continent, with experience, with knowledge that we hope will enlighten our audience and address some of the questions as we prepare for the main launch of the Lancet-WPA Commission. The first panel member that I would like to introduce is Dr. Dickson Chibanda. Dr. Dickson Chibanda is famous in these parts for his innovation of the Friendship Bench. He's a commissioner with the Lancet Commission, and is currently leading a team to scale up the Friendship Bench to over 60 primary healthcare clinics in Zimbabwe. He's also the director of the African Mental Health Research Initiative, which brings together many researchers looking at relevant questions in mental health across the African continent. The next panelist that I would like to introduce is Liz Kakoza. Liz from Uganda is a person with lived mental health experience. She's a passionate mental health advocate who has, over the last 6 years, championed awareness of mental health in Uganda and across the African continent. She founded MindLab, which is a nonprofit whose aim is to democratize mental health care and support in Africa through awareness, advocacy, and access. And we will be hearing a lot more from her shortly. The next person I would like to introduce is Professor Bonginkosi Eliza. He will tell us if I have pronounced his name correctly. Bonga is my friend and co-conspirator in many areas in mental health across the continent. He's an associate professor and head of the Department of Psychiatry at the University of KwaZulu-Natal. He's also the immediate past president of the South African Society of Psychiatrists. So since African presidents don't go away, he's President Eliza. He's also the deputy editor of the South African Journal of Psychiatry and has received several awards, including the Hamilton Naki Clinical Research Fellowship and research grants from international funding agencies. The next panelist is Dr. Florence Baingana, who is also a psychiatrist and a public health specialist. Currently, she is the WHO African Region Advisor on Mental Health and Substance Use. She has practiced psychiatry in Uganda for many years and worked with the Ministry of Health in Uganda since 1996, establishing the Mental Health Unit, and was co-lead for the core group on the Northern Uganda Psychosocial Needs Assessment. In the year 2000, she joined the World Bank in Washington, DC, where she worked on conflict and post-conflict countries, Sierra Leone, the West Bank and Gaza, Burundi, and Afghanistan. And we're going to hear from her also on perspectives from the World Health Organization. The next panelist that I would introduce is Dr. Victor Ugo. So Victor Ugo from Nigeria is the founder of Mentally Aware Nigeria Initiative, one of Africa's largest user-led youth mental health network. Mentally Aware Nigeria Initiative, with over 1,500 active volunteers and chapters in 15 out of 36 states in Nigeria, is, as you can see, very impactful in that region of the continent. He won the 2017 Nelson Mandela Graça Machel Innovation Award for the best civil society organization and has been inducted as one of the 100 sparks of hope across the world by the Elders. The Elders is an organization of past world leaders founded by the late Nelson Mandela, President of South Africa. So with that introduction, we will go straight into the panel presentations. And we have arranged them in such a way that we hope our audience will be able to engage with the presenters. There will be firstly a brief presentation from Commissioner Dr. Dickson Chibanda, who will give us perspectives from the Lancet and World Psychiatric Association on this commission. Dickson, the floor is yours.
Thank you very much. I'm really honored to represent the commissioners. And in my capacity as commissioner, I would like to just highlight some of the high-level recommendations. So really, the commission believes that reducing the burden of depression requires united action by diverse stakeholders. And I would just like to spend the next few minutes to touch on some of the key stakeholders that we are referring to here. So the four key stakeholders include healthcare practitioners, decision makers, or your policy makers, if you like, researchers, and the general community. Just to touch briefly on some very specific recommendations for each of these groups. I can't go into all the recommendations, they are quite extensive, but these are all available in the published documents. So with regards to the healthcare practitioners, it's important if you're in this space to be proactive in recognizing early the risks and consequences of depression. We encourage you to learn about the many presentations of depression and about the lived experience of the actual illness itself. We encourage to personalize your approach. One size does not fit all. So we really need to be very much client or patient-centered in our approach to managing and trying to help people who are living with depression. With regards to decision makers, we really recommend that decision makers strive to respond to the experience of people with depression and to the science. Invest in early intervention and sustained depression care. Support the scaling up of community and rights-based depression care. And moving on to researchers, we encourage researchers to design and test therapies that address early and novel interventions within this space that focus on depression, and of course develop precision medicine approaches for prevention, care, and recovery. And then I'll just conclude with the general community. What can the general community do? Some of the things that we have recommended include, the general community seeking help early, because it increases the chances of prevention and recovery when you seek help early. Talk with family and friends, including people with lived experience of depression, because knowing that depression is actually a common human condition. So that's quite critical to capture. Depression is a common human condition. Always remain hopeful. Most people will recover. Seek evidence-based care. Focus on support for your own priorities. So it's, how can we make evidence-based care a low-hanging fruit on the continent? This should be one of our objectives as we strive to really narrow the care gap for depression on the continent. I'll stop there. Thank you.
Thank you. Thank you very much, Dixon, for framing the conversation today based on the findings and recommendations of the Lancet Commission. And as we go into the panel, I know you have mentioned repeatedly that, you've mentioned lived experience repeatedly in your presentation, and I think it is important that we begin indeed with hearing the perspective of a person with lived experience, and this is where Liz Kakoza comes in. And I would like to frame your panel contribution with a question, and this is, we've heard about lived experience all over the place, but we want to know from you, what has it been like as a person with lived experience in Africa? Are there any peculiarities to being a person with lived experience in Africa compared to what we know from other parts of the world and so on? So Liz, please take it away.
Thank you, Professor Lukoye, for the question, and for Pascal's brain and Mike for having me join this panel. Has been mentioned, I bring my lived experience to this work in mental health, and living with depression and anxiety in Africa is quite different. What we see in the West or in the developed world is, yes, there's still a lot of work being done, a lot of research being done to better understand depression. but it's still a very new idea on the African continent. So that informs things like, access to care, something as simple as, medication, or finding, the right professional to, work with you to receive care and support. So it makes the process so much longer and so much more difficult. This, of course, you could attribute to one, of course, there's the stigma around it. So because of that stigma or that lack of understanding, it's not it's not a priority for, in terms of policymakers, for decision makers and different stakeholders. So for people living with, these challenges, for people living with depression, such as myself, it makes the journey so much harder, so much longer, and much more difficult, as opposed to if I was living in, the developed world, where, it's easier, it becomes much easier to receive access to support, or, to support and care in whichever shape or form. So yeah, in summary, it is much more difficult, and there's a lot more that we could do collectively.
Thank you very much. Yeah, this builds very well from what Dixon was saying, and how we need to understand the actual experience, and that no size fits all. And I would argue, therefore, that no size fits all, neither in treatment nor in the diagnostic process or the experience of depression and anxiety on the continent. So thinking about making things a lot more personalized. And talking about context, then, I would go back to Dixon and ask, again, based on the innovation that you have made in Zimbabwe, the Friendship Bench, that Africans in general, and this might be, an overgeneralization or a cliche, but it seems like it bears out, that Africans in general revere the elderly. And, older people are given a lot of respect on the continent. And so the question to you is, how do we then better include the elderly? Because we are making a lot of efforts getting young people enthused and engaged in mental health interventions. Where do we bring in the older generation in bridging the mental health service gap? And how do we upscale your innovation, your contribution to the mental health treatment gap, what you've done with the Friendship Bench in Zimbabwe?
Thank you. I just want to start off by emphasizing that the elderly in any African culture are the custodians of local culture, knowledge, and wisdom. That's the first starting point. And how do we tap into this resource, this richness from Cape to Cairo? We tap into it by acknowledging and embracing our culture as Africans. One of the challenges that we face in global mental health is the rejection of our own culture. The rejection of local idioms of distress, the rejection of the richness of our understanding and the context at local level. So to actually grow as Africans, particularly academics, we need to learn to embrace our culture as we figure out how best we can use knowledge that is coming from the West. Not everything that comes from the West is appropriate for African culture. So I think, to answer your question, how can we scale? First thing is to recognize the unique resources that we possess as Africans. Understanding that in Africa, from Cape to Cairo, we have these isolated pockets of excellence. When you look at the way we use culture to navigate through challenges, when you think of the way we use culture to respond to some of the psychological issues that we are facing. So the critical question is, how do we bring in lessons from the Commission and bring in aspects of our own Africanism and culture to try to scale? Because the focus here is really on on using, non-professionals. We want to use non-professionals to narrow the care gap on the continent. Just recently, WHO reported that Africa has the highest rate of suicide. 6 of the 10 countries in the world with the highest suicide rates are in Africa. But we need to be asking ourselves, where is that coming from? What is the link? In Africa, we cannot ignore the importance of social determinants of mental health. So as we design these culturally appropriate innovations, we need to also be thinking about the importance of some of the social determinants of health. But really, the key take-home message here is embrace your culture, work with the elderly. Intergenerational connectedness is a real tool that we can leverage in our efforts to narrow the care gap for depression. Thank you.
Thank you very much, Dixon. And I agree that, so in a manner of speaking, there's this African metaphor of when it's raining and there's a hole in your roof. And some people would rush to put a bucket under the hole in the roof so as to collect the rainwater instead of fixing the hole in the roof. And in our case, starting way upstream and dealing with these problems using culturally available and accessible resources might be a good way to start, instead of waiting for people to have severe mental illness and start worrying about how they should get treatment. And this brings me to Bonga. Having said these things that we have said, what kind of research should we in Africa be doing in order to improve the quality and quantity of mental health service delivery in respect of depression, anxiety, and probably in respect to the entire range of mental ill health on the continent? Bonga.
Sure. Thank you very much, Lukoye, and thank you very much for having me on this esteemed panel. So I think Dixon has really touched on the 3 things that I wanted to mention up front, and maybe I'll just maybe repeat what he's just said in a different way. But basically, there's very clear to me that there's, as researchers on our continent, we've got to be doing research that addresses our needs. And so, when it comes to mental health, it's very clear that, social determinants of mental health are so important. So in Africa, we've got issues around poverty, we've got food insecurity, we've got trauma or violence. Really, that really does make a huge difference in the lives of our people, making them, towards depression and other more serious mental illnesses. So yeah, so I agree that that's what we should be trying to address when we're trying to do research. I think, secondly, I think that we should also be focusing on our strengths as a continent and saying what is our strengths as a continent that could help for us to meaningfully contribute to the global sort of literature around research literature around depression and other mental illnesses. And the first one, I agree very much with Dixon, is definitely what we call indigenous knowledge systems. So there are many examples of this, but in South Africa, in Zulus, we call them gogos. Our grannies have got so much knowledge when it comes to mental health that they are sitting with. So, for example, in South Africa, where you come from, people are very clear that if you've got a child that has behavioral sort of disturbances, that is perhaps a little bit more hyperactive than usual, there's a special diet that you give for them, which you use certain green leaves diet, which turns out actually is basically a ketogenic diet, which the basic scientists are also examining and showing that it does help with behavioral symptoms in mice and other people like that. So there's this knowledge that they're sitting with, and we should really be trying to tap into it. I think that we should also be proud of the fact that we have healers who use African traditional spiritual ways of healing our people. And we should be trying to embrace healers that are perhaps ethical and use humane methods of doing this, and we should be working together with them. And our people that we are seeing as psychiatrists on our continent actually vote with their feet, because they leave our hospitals and actually go to healers anyway. So there's something that the healers are putting to the table that perhaps is a strength for our people that we should be trying to see how we can embrace. And then lastly, I think, having said that, there's a lot of trauma, there's a lot of violence on our continent. There's also a lot of things that we do right that are actually protective. As you know, Lukoye, you the guru on trauma, and we know that many people that have these traumatic events don't actually get severe illnesses like post-traumatic stress disorder. And so studying that perhaps would really make a huge contribution to say, why is it that so many people are exposed to these horrible violent attacks, but they don't actually have mental illnesses? So those are some of the things that we should be looking. And I think how we do it as researchers also needs to change. So I know that Liz may agree with me that, kind of co-creating research with people with lived experiences is the buzzword that, globally that everyone's going around talking about. But, we need to do that a bit more meaningfully in Africa. So not just involve them because you're putting in a grant together, but sit down with people with lived experiences and say, what do you think would be useful for us to be studying in this center, given, what we can do. There's no doubt that a lot of the tools that we're using for research need to be culturally congruent. So we can't just transport, these tools that they use in the global north and say that this is what we should be doing. And then I think lastly, very much in keeping with Commission, I think we should be looking at research that is truly intersectoral. If we are having all these challenges that are so vast, we should be saying, how do we pull in people from different sectors of government and sit down with them before we even start the research, as opposed to kind of going to them afterwards and saying, hey, look at what we found as researchers, and I think this is what you guys should be doing. I think it would be useful to get their inputs before that. It really would make it probably a meaningful way of changing the way that we do research. Thank you very much.
Thank you, Bonga. I think you have covered the entire breadth of what Africa brings to the table as far as research is concerned, and what kinds of problems we should be studying if we're going to have an impact on the continent. And so having said that, then we start looking at the roles of governments and groups of governments. What are they doing as far as mental health needs in Africa are concerned? And what more can be done? And I would like to bring in Florence Baingana to give us a perspective of World Health Organization and what role the World Health Organization is playing in mental health in Africa. Florence.
Thank you very much. And thank you for inviting me to be a part of this very esteemed panel. I'm really glad. I hope you can hear me well enough. Okay.
We can hear you, thank you.
Okay, very good. So the role of WHO, and as you rightly said, the WHO is a grouping of governments, and it is the governments together that come together to determine what it is that should be done, and actually even put in the money that supports the work of WHO. I'm glad to report that in the last 2 years, we have had some 3 documents passed at the World Health Assembly, WHA, World Health Assembly, 1 in 2021 and 2 of them in 2022. One is the Comprehensive Mental Health Action Plan. This is from 2013 to 2030, but as you know, the annexes were revised and it has been extended to 2030, and that a few changes were made in the annexes as well, impacting as a result of the different changes going on globally. We also had the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders passed endorsed by the World Health Assembly last year, as well as the Global Alcohol Action Plan, also endorsed last year. So these three documents together, I think, are very critical because they bring together three very critical areas for the African region. And as the African region, in August of this year, the framework to implement the Comprehensive Mental Health Action Plan in the WHO African region was also endorsed by the Africa region governments. And it was actually overwhelmingly supported throughout the process of its review. There's a recognition among our governments that mental health is a critical issue. It should be prioritized. The governments agree they should be doing more, and they overwhelmingly committed to do more. So I think now we need to call on them to implement it. It's available on the web, but should you need a copy, I'm happy to provide that. So that is one on the global sort of strategic documents developed. But if we look at action, what action are African governments actually taking, and what support is WHO providing? I forgot to mention that the focus of the implementation framework is going to be on strengthening services at the community level, community and primary care levels, because these are the weakest in our healthcare system. We know that most of the services in our region are provided by big psychiatric institutions. Most are in the capital cities. We feel the need to decentralize services down to the lowest level of care, the community, as well as the primary health care levels. So this is what the focus is going to be for the next few years. On top of this, there's going to be a focus on young people. They make up the biggest population in our region. About 60% of the population is below the age of 24 years. So it's quite it's a resource. I think it is a resource if we look after them well enough, and if we prevent mental health problems, promote their mental well-being, we have a big return we could make out of this demographic dividend. So that is what we hope to be focusing on. So that is that. But coming to the actions on the ground, I will go through very, very quickly. I think one of the biggest one is the Special Initiative for Mental Health, which is a focus. The Director General himself initiated this focus on mental health, and it's providing support to 2 countries in our region, but 9 countries globally. And should funding allow, we shall extend to other countries in the region. So these ideas that I talked about earlier about strengthening services at the community level are actually being implemented in the 2 countries, Zimbabwe actually, and Ghana. So the countries developed frameworks that they are now implementing, and they are getting more intensive support than other countries would get. So that is one. Actually, within Zimbabwe, the WHO is working with the Friendship Bench to see whether the Friendship Bench can be scaled up even within Zimbabwe. So the implementation of the Friendship Bench had not scaled countrywide. So that is what we hope to do. And discussions have begun as well to see whether we can replicate the Friendship Bench in Rwanda. So the idea that our own homegrown innovations should be replicated or scaled up within our countries is something that we support very much as WHO. Last year, the Director General held the first innovations showcase that focused on 3 innovations and mental health innovations. This was the first innovations showcase. It was a global event, but hosted by the African region. And the 3 innovations were African innovations. So the Friendship Bench was one. The second one is SIG, ISP, GSP. SIG GSP, which is a Ugandan innovation, again, community support for people living with depression. And the third one is ACMAAD, it is from Ethiopia. So this idea that we are going to support the scale up of innovations from our own region that respond to the needs of the population is something that we are definitely going to be supporting. The other is mental health per se gets very limited funding, even within WHO, especially within the African region. So one way that we hope to increase the support to mental health, for instance, is to integrate into other areas. We are integrating mental health modules into NCDs management. So some of you may have heard of Pen Plus, which delivers a package of services at the primary care level for non-communicable disorders. So we are integrating mental health in that, and the module very often integrated is the depression module, because we know that when depression co-occurs with the non-communicable disorders, the outcomes are not very good. So we are now focusing on seeing how we can have these conditions treated together for the best outcome for these patients. This is being done as well for TB, as well as for NTDs. For NTDs, we did programming in Nigeria. For TB, it was done in Kenya and in Ghana again. So this programming, which is done, is to test it out and see how effective it is, how other healthcare workers welcoming to have this kind of joint programming. And indeed they are. So this is being done. On top of that, perinatal mental health has a big role to play in early child development. So we have integrated that as well, and this is being implemented in Kenya, in Tanzania, and in Mozambique. But at the same time, we have just received as well some funding from USAID, and we'll be rolling out in 7 countries. I think I've gone on too long. Not to leave out the minimum services package for MHPSS, mental health and psychosocial support. So WHO does a lot of work. As you know, our region is overwhelmingly affected by conflicts and other complex emergencies. And mental health and psychosocial support is an integral part of the response. Right now, we are supporting 5 countries to integrate the 2 pieces together, NCDs and mental health in the conflict response. I will stop there for now. Once I get going, it's very difficult.
Thank you, Florence.
Yeah.
Thank you. I think it appears to me that we probably need another webinar to look at what A, governments in Africa are doing, but B, what WHO is doing to support them in order to improve mental health on the continent. Seems like there's quite a lot. However, usually sometimes what is said officially might not be happening on the ground. In Kenya, we have a saying in Kiswahili, contemporary Kiswahili, that says, kwa ground, vitu ni different. In other words, on the ground, things are different. And I want to ask Victor, and I will come back to you, Liz, very briefly after Victor speaks, so that Liz, you can confirm whether kwa ground, vitu ni different. Victor, I wanted you to, probably from a Nigerian perspective and from the perspective of a CBO, to tell us a little bit about what prompted you to found this initiative of Mentally Aware Nigeria. What niche were you seeking to occupy? What problem were you seeking to solve? And also, do you think the governments in Africa and in Nigeria are doing as much as we expect them to do to deal with this problem? Victor.
Thank you. I think there's a lot of common themes that I've had throughout this conversation today: lived experience, localization of language, and I think that's really important. In terms of what prompted me to start up this organization, I think when I was in medical school, I was diagnosed with depression. So it was my lived experience mainly that prompted me, but I think it came from a place of privilege because um, I was lucky enough to have access to services as a medical student and knew where to get support. And I assumed that was the case for a lot of young Nigerians at the time. Um, but I was exposed to an incident that sort of brought me down back to earth really. And that's essentially why we started the organization Money. Some of the key things that I like to focus on is the problem of language. I think most times one of the reasons why we have a huge misunderstanding of mental health and stigma and discrimination comes from a lack of understanding of the terminologies and the language around it, which makes it easy for people to reject it. So I think one of the key things I wanted to focus on at the beginning was trying to look at what was the local language, how do Nigerians understand mental health from their own perspective and understanding, and how do we make sure that this is communicated clearly to people, and what kind of people do we want to engage to get this message across board. So it was important for us at the beginning to go to the population of the willing, and that was young people, and that's why we used social media as one of our initial avenues or channels for propagating the message at the time. But one of the things that we learned in the process was that awareness can be dangerous. It can be dangerous to do just awareness if you don't have any referral mechanisms on the ground. You don't have any place that people can reach out to and people that they can talk to. At the time, whenever we post something, someone will say, "Now you have told me about depression. Where do I seek help?" So again, we learned a lot while doing the work itself, and then we learned from just going back to some of what Dixon mentioned about older people, the older generation being the stalwarts of the culture. I sort of applied some of my own learnings and lessons from my father. My father is a clergy, and I think growing up, I watched him going to communities, and he was trying to propagate obviously Christianity at the time. And what I learned from that was how localized advocacy is. That I consider religion and evangelism, and trying to get people to hear you out. People that have no experience or no understanding of a particular concept, I consider that a form of advocacy. And one of the things that I always mention to people is to think local when you're thinking about innovations that can serve a particular region or a particular context. You need to think locally. You need to look at what has worked in that context, and then you use that to create your own strategies and approaches to creating solutions to it. In terms of the last question you asked about what's the reality on the ground, I can say for sure that I don't think we have had as much movement when it comes to mental health. There's a lot of commitment publicly and on global fronts where you have ministers of health talk about what they're doing, but practically on the ground, there's not much movement. We still have a very reduced budget, maybe even less than it was, 5 years ago when we started the project, 6 years ago when we started. I think now we even have lesser budget for mental health. We still have the cake law in Nigeria, which we've been trying to change for years, and there's not been as much government, should I say, interest or focus or sanction for the laws that we've been trying to push. In Nigeria, suicide is still considered a crime. And there's little or no movement on that. So across different African countries, I think it's the same. Some people have moved forward. Kenya, they've new laws. Ghana talking about financing, but coming to the biggest population in Africa, there's little or no movement in mental health. So the reality on the ground is stark, and I can say it's going to change anytime soon.
Yeah. Very good. Thank you, Victor. As Victor says, it is indeed true that kwa ground vitu ni different. In other words, on the ground things are different. But I think as you point out, Kenya, Ghana, and other African countries provide a glimmer of hope that things can change if there is commitment from the highest office that says, mental health is a priority and we need to do something about it. There is always a possibility that things can change. I would like Liz to speak to this and tell me whether in neighboring Uganda, which is just next to Kenya, there are also reforms in mental health and they're feeling some kind of impact on the ground.
Thank you. So, same, just to echo what Victor said, it's the same for us here. Things aren't much different. Background, definitely things aren't moving in the direction that we would hope to be, that where we hope to be, in the next couple of years. Yes, suicide is still criminalized. It was a major topic of discussion during the recent World Suicide Prevention Day. Which has never made sense to me, because what do you do then if someone has already died from suicide? And it's something that I've experienced over the past year as we've had an influx of suicides, and I've experienced, suicides around me. So that in itself also doesn't do much in addressing the stigma, right? Because suicide is criminalized. Then you only have, you only perpetuate the stigma in that instance. So yes, there's still a lot of pieces that we need to put together. Funding is still very limited. I think we're at under 0.5% of the healthcare budget now for mental health. Yes, just like Victor said, there's a lot of commitment publicly. From a political standpoint, but implementation, we're still doing very, very poorly. There's still a lot that we need to look into in terms of how do we design care into our healthcare systems. We've talked about throughout this conversation. We've talked about using already existing structures within our communities, the elderly, the traditional healers, religion or religious leaders. And these, I think these are areas in which we need to, just like everyone has said here, we need to place emphasis on or focus on in terms of, creating points of care within these different sections or segments within the community. So in summary, on ground, things are completely different.
Thank you very much. So, so it means that there's a gulf to be bridged, and I think as was pointed out by Dixon and by other speakers, we have the young people, and as Bonga pointed out, we have the elderly. And there is an opportunity to bridge this divide between where we want to be and where we are on the ground. I would like us to move to the question and answer session. Thank you for the participants who have been following this conversation, and quite a number have started putting out questions that we would like to address. And I think stigma, so we start with social determinants. So we have discussed, and all the speakers agree that social determinants are key contributor to mental health or mental ill health. And so the question is asked that, having identified this central role, what next? What should we be doing, and what are the implications? I would like Dixon to speak briefly to this, and then we get some kind of way forward, and we might hear from another panelist before we look at the next question.
Thank you. So I think, with regards to social determinants, we want to be developing interventions that are not over medicalized. You see, the unfortunate thing is a lot of the frameworks that we've used in Africa to develop interventions are frameworks that have been developed in the North. And this is one of the reasons why sometimes our people do not identify with the terminology that we use. Because if someone, in my language, depression is called kufungisisa, which literally means thinking too much. Now, if you ask them why they have kufungisisa, they will focus on a social determinant. It could be violence at home, it could be some kind of issue related to poverty, and so I think what we need to be doing to address that is to think of interventions that also address these social determinants, and not just thinking of reducing the depression scores, because traditionally this is what a lot of interventions do. They focus on reducing scores based on some validated screening tool, whether it's the PHQ-9 or GAD-7, whatever it is. We really need to be thinking of reducing social determinants that are affecting or leading to mental health issues. And we can only do that by engaging communities, by immersing ourselves in the communities and engaging the community gatekeepers. And in our case in Zimbabwe, it's the elderly, the grandmothers, because they really are the custodians of the local culture, wisdom, and knowledge. I'll stop there and let the others respond to that too. Thank you.
Yeah, and I wanted to also throw this to Zul, because in his opening statement, he talked about focusing on different segments of the population rather than going to the tip of the pyramid with innovations, but starting where the majority of the people are before they get severely ill. Zul, do you see this as a locus for social determinants interventions?
Absolutely. Thank you,
Thank you.
Lukoya. I think that absolutely addressing the needs of at the community level is critically important. And Dixon makes a very important point in the sense that it doesn't mean just the individuals within the community, but it also means community at large. Of how do we change the mindset and how do we increase the awareness? Because one of the other questions that was raised in the question panel was that how do you help somebody who, for example, doesn't believe that he or she is depressed? And that boils down to whether people even recognize depression as a condition. Culturally, we need to have a context that's very appropriate and people can relate to, because if they can't relate to that, then there's nothing you can do. So I think building the awareness and engaging the communities together, I think that is the area that will really make the biggest impact. The North American approach always has been very more medically oriented and top down. What we are now talking about from our cultures in Africa is how do we really rise bottom up, and the strength I think is there, and the innovation will come from there as well. But the challenge is how do we do it? I think Dixon's innovation was very effective from that perspective. But what else can we do in addressing the social determinants, not just at the individual level, but at the community level, and to raise that? Thank you.
Yeah. Thank you, Zul. And so tying in social determinants and stigma as you have done, thinking through how do we use the social capital on the continent to improve care, prevent ill health, and reduce stigma. I would ask Bonga if there is any evidence that has been generated on the continent around using existing, social resources to deal with these issues, care and stigma.
No, thanks, Lukoya. I think, I really want to agree with what has been said previously. So the one area that has been written up quite a lot about in our continent is the issue of trauma and the care for people with who suffer from severe trauma. And even the word trauma is a bit problematic, but basically violence. People that have come back from wars, or people that have got interpersonal violence. There's a lot of work that's been shown that there is a lot that the communities can do without psychiatrists and without psychologists, because we don't have psychiatrists, psychologists. There's quite a bit of work been written, for example, by the child soldiers returning from war in Uganda, in northern Uganda, who these elderly women had to deal with them because there were no psychologists. So there are definitely ways and means that we are aware of, that we know that one can care for people without necessarily needing highly qualified specialists on our continent. When it comes to stigma, there is still quite a bit of work to be done, I think, around understanding the impact, well, not necessarily the impact of stigma, but really understanding how best to try and help fight stigma against mental illness. There is, as just like this commission, there's also another commission that just recently got published on stigma and discrimination. And I think it'll be wonderful also to have this kind of discussion to say what is it that is possible that we should be doing to reduce stigma on our continent. A lot of it has got to do with, obviously, with education, but often not just public awareness or education, but often we also need to look at what we're doing to people with mental illnesses that is often also increasing the stigmatization or the self-stigma. So yeah, so I agree with you, Luca, that there's a lot to be done in the community, and we should be focusing perhaps a lot of our work on that area.
Yeah, thank you. I think the point that you're all raising is we shouldn't behave like politicians who have a very short frame. Like, you know, if I do something, I must see results before the next election. But we should act like true Africans who plant a tree for the next generation rather than planting trees for themselves, and think about interventions that will prevent problems 10, 20 years from now, rather than waiting for problems and trying to find quick fix solutions. And this brings me then to this question that has been asked about technology and how can we use technology to mitigate mental health issues. And I want to throw it to some of the young people on this panel. Victor, what do you think we can do with technology to help with mental health on the continent?
I mean, the truth is that we cannot avoid the fact that we're in a global village now, where we have a lot of young people using social media and have access to digital tech, which means that we have to create solutions that can actually meet them where they are. So we definitely can use technology, and we're already using it. Some of the things that we can do using technology is to increase awareness, increase access to services, make sure that we've created mechanisms for referrals that are easy to access for people that need it and when they need it. And rather than building new technology, there's already existing tech out there. You know, people use WhatsApp. I think Friendship Bench uses WhatsApp. A couple of organizations use WhatsApp to connect to young people that need support and help. But we also have to be very careful, because I think when it comes to tech and mental health, there's a lack of legislation around it, especially in the African front. There's a lack of legislation around safety. There's a lack of policy about data and what people do with it. So we have to make sure there's a good balance between addressing the safety and access to those services for people that use them, and also making sure there's enough work being done and that people can have access to mental health services and information and opportunities as needed.
Yeah, thank you, Victor. And I was just saying here that we also want to hear the perspective from Florence on is there some kind of official drive or policy or direction around use of technology in mental health that we can use on the African continent?
Maybe before I get to that one, I had wanted to respond very briefly to Victor and saying that no progress is being made in Nigeria. I just wanted to say that Nigeria is one of the countries that commits 5% of its budget to mental health. Unfortunately, it's a huge country, and so the 5% may not be going very far. Nigeria very recently actually put in place a position for a mental health person in the Federal Ministry of Health, and they are right now recruiting for a mental health person in the WHO office, somebody specifically for mental health. Most of our offices, one person covers NCDs, this and that and the other. So sometimes the progress is very slow. They say if you put a frog in water and then slowly warm it up, the frog will not realize that the water is heating up. And I think in Nigeria, things are changing, and globally, and even in Africa, things are changing, but the change is very slow, because these are policy changes that have to then translate into actions on the ground. To be felt, it takes time. I just want also to comment very briefly on the social determinants question. It's really important for us to engage with other sectors. I think it was mentioned by somebody else: education, social protection, social welfare, livelihoods. You know, we need, just like Dixon said, to work outside of our normal ways of working. One way we have been doing this, for instance, in Sierra Leone, we, with UNICEF, were going to not prisons, they are called reform homes, children in conflict with the law. So you're not going to find the children on the street who end up in these institutions for children in conflict with the law. One way that we can access care to them is going into these homes and providing care there. And this is something that was done there. In Sierra Leone as well, they have done a lot of work with child soldiers, following them up over many years. One researcher, Teresa Betancourt, has done that, and working with UNDP, they have also supported the livelihood side. And this is linked to mental health support, so that the two have to be provided together. And this leads, they are looking at the outcomes for the children of those child soldiers now. So there's a lot that's being done. It's just that unfortunately we may not be seeing it. But when we come to technology, we did some work on that in relation to COVID-19, looking at how have we responded, how have we used technology to respond to the COVID-19 pandemic. And unfortunately, Africa was not doing as well as other regions of the world, mainly because of issues like data, and then how many people have access to smartphones, you know, the cost of the data, how many people have access to smartphones. But I think that too is picking up slowly. Those in the urban areas are already doing online consultations almost routinely. So you don't always have to go in to see your provider. Sometimes you can do it online. So young people also can get their different, I think they are called bots, different things you can access services. Yeah, so if you need information, you can get that information through AI and things like that. So
yeah. Good. Thank you, Florence. Very comprehensive. And I see Zul wants to contribute, I suspect, to the tech question. Very briefly, Zul.
Yes, thank you very much. I think in terms of using the technology, one of the potential approaches we have used recently is to create an app on a tablet that the community health workers can use to screen people at the door about their level of depression and anxiety. But not only that, then be able to be guided about what kind of supports they can provide before referring them up to higher levels of care. And in a nutshell, what we are finding is that in 150 males, 50 females that we have tested this on, that even though we didn't provide a therapeutic interventions per se, just by asking them about and assessing their mental well-being and giving them some guidance about relaxing and breathing exercises and things like that, that the scores fell significantly, very rapidly after about 6 sessions. So it tells me that sometimes you don't need high levels of care. Like if you intervene early using technology quickly, that you would have a huge impact on using lower levels of care providers to fill the gap. Thank you.
Yeah, thank you, Zul. I liked what Victor said, that sometimes when we think about technology, we think it is going to be very complicated stuff. It can be as simple as putting people together in a WhatsApp group to address challenges that they're facing on a day-to-day basis, to provide problem-solving, innovations, and so on. So that's important for us to keep in mind. There's a question here about increased cases of depression and suicide among police officers in Kenya who have access to lethal means. And so the question is, what what interventions can we put in place to deal with this? And also, if there's anything happening on the continent regarding mental health of police officers. And I would probably want to hear from the South African perspective, then we might want to hear from Nigeria as well. So Bonga, is there anything happening with police officers in South Africa?
Thanks to Corey. No, we don't. I'm not aware of any specific programs that are there with the police in terms of interventions, but we do know that there's the police and in our country also the teachers are the ones that have got very high rates of trauma and depression, and they, luckily for us in this country, they have fairly decent medical insurance, most of them, and so that gets seen quite often by psychologists and psychiatrists in the private sector. But I'm not aware of any specific programs that are kind of trying to deal with that at the moment.
Yeah. So I think one of the reasons this question is put up, I guess, is because the Kenya National Police Service has set up a mental health service within the police service that addresses the mental health needs of police officers of all formations. And this is partly in response to, the increasing evidence of mental ill health, suicides, and homicides within the police force. I don't know, Victor, if you're aware of any specific innovation for police officers in Nigeria.
No, I'm not aware. I think following there was a protest against police brutality in 2020. Following that, there were some recommendations to have and provide mental services to police officers, which was led by civil society organizations within the country. I don't think that was institutionalized. Some states took it forward, and most states didn't. So that's as much as I know.
Mm-hmm. And Dixon, maybe you can give us a perspective from where you sit.
Thank you. Yeah, so I think one of the things that we're doing actually in Kenya, where we've launched, a few years now, we have an app which is called Inuka, which is a Swahili word. It means arise. And Inuka is based on the principle of friendship bench. We piloted Inuka in Zimbabwe and in Kenya and in the Netherlands. And Inuka is available and is accessible, but probably the problem that might be happening is that a lot of people might not be aware of Inuka, but it is a platform which provides anonymous, structured therapy and the option of being referred to a higher level if there's a need. And I think this is something that we could probably try and push more in Kenya. I know that a few police officers have utilized Inuka in Kenya, but we've had predominantly teachers utilizing it. So that's the only thing I can really share with regards to what could be immediately available for police officers that we are working on, particularly in Kenya.
Yeah, thank you very much, Dixon. I want to move to the next. I see Claudia. Claudia, I'm sure you can show up on the screen. Maybe yes, and you probably want to introduce yourself very briefly and then say something about what this question from Brazil about youth and elderly friendship bench, something like that. Please, Claudia.
Hi all, thank you so much for having me. It's such a great panel. I am a commissioner also, and I'm from Brazil, and I am sort of provided support to the commission for a number of things and a number of events that we had, regarding regional launches of the commission on depression. And yeah, so I'm, I have a Brazilian perspective, but I think we have a lot to learn and a lot in common with Africa. You know, what the Dr. Bengena said about youth, you know, we have a lot of young people here. I think, I'm not sure we can say the same thing about having, you know, this important role of the elderly. Brazil is also a huge country. We also have a language issue. For example, I think representation from Brazil is usually or often reduced because fewer people speak English here. And I think this is also something that would interest me in terms of even like sharing information, like Dixon was just saying now about, you know, things that are in place but don't get disseminated. Perhaps language is a barrier. I'm not sure about that, but how can we disseminate more across vast geographies, you know, the things that are already available. But it has also always occurred to me whether we could join, you know, is it feasible to join youth and the elderly, you know, in a initiative like the Friendship Bench? Has it been tried? And would that, you know, one of the things that we have been discussing here, I work with the children and adolescent depression, is the issue of linking the you know, sort of more grassroots initiatives to the services, to the more complex services, and could a navigation system, you know, help that in terms of youth being able to really take people sometimes very practically, you know, by the hand to a service when it's available. So thank you so much. This is really a great panel. And these are my points or questions or thoughts.
Thank you, Claudia. And very thought-provoking. I'll give Dixon maybe a minute or so to respond to that, and then we will move to this next very important question. Dixon, do you want to think about a bench that brings the young people and the old people together? And then the second thing is, I know Amari has a network for bringing together researchers, but do you also have a network for dissemination, as Claudia asked?
Yes, sure. I'll start off with the first one. So we call it intergenerational connectedness when you bring the elderly in communities with the young people, something that we are increasingly doing at the Friendship Bench, because the young people bring to the bench skills, particularly digital skills that enable the grandmothers to learn how to use smartphones, because the grandmothers have to upload data about their clients that they see. So we have that sort of two-way learning where the young people equip the grandmothers to use digital platforms, and the grandmothers in return help the young people to be grounded, to have a sense of purpose within their communities. And we actually are seeing that you know, connection between the young and the elderly is beneficial for both sides. So it's definitely something that we need to tap into in Africa, particularly at community level, where we really bring the different players within our communities to collectively problem solve around the different challenges that we are facing. Second one was on Amari. Yes, indeed. You know, Amari 2 hasn't yet started, but we are about to start. But the opportunity for networking through Amari is huge. Amari 2 is going to have several hubs in Africa. We will have an East, West, and Southern Africa and Central Africa hub, where we will be working together with a number of institutions across Africa to strengthen these networks. And as I indicated earlier on, one of the challenges we have in Africa is we have these isolated pockets of excellence. And one of the things that Amari is trying to do is bring all of these isolated pockets of excellence when it comes to mental health, to really try and work together for impact across the continent. Thank you.
Thank you very much. And the last point to make about bringing these isolated pockets of excellence together so that they have greater impact is a strong point that I know the Brain and Mind Institute is very, very interested in. And I know that Zul will be reaching out for in-depth conversations around how do we do this, because it is something that the BMI has been also thinking about, creating such a hub that brings together everybody working in mental health in Africa. There's one point that I would like us to again address because it is relevant on the continent. And then after this, I'm going to ask each of you panelists to give us one takeaway point. So prepare a takeaway point even as we address this question on culture. This question is asking our medical doctors what we are doing to research into issues of culture, especially spiritual interventions by spiritualists who include modern pastors as well. And this is a question that I know Bonga might be well placed to answer, because there has been a lot of work that traditional healers do in South Africa that intersects with what the mental health professionals do. Is there much research that is being done on this phenomena?
Yeah, no, thanks, Luca. Yeah, definitely. There's a huge amount of scope for us to do more work on this area. We are doing some work in this area. We are particularly interested in how traditional healers or spiritual healers are able to get people with severe mental illness into recovery. As you know, that biomedical doctors think once you have a severe mental illness that you are doomed to have this illness for life, and it's, there's poor prognosis, etc. And so a lot of the work that we are doing is trying to integrate with them to do this work so that they can help our people to get into recovery. Professor Oyegureje also did a fantastic trial, a cluster-randomized trial in Nigeria, where he worked with healers in Nigeria and Ghana, I think, and they showed that working with healers in those regions can actually improve or shorten the time it takes for individuals with severe mental illness to reach psychiatrists in that area. So decrease the duration of untreated psychosis, if you may, or untreated illness, if you may, and therefore, hopefully, that improves, equates to better outcomes. So there are people that are working in this area, and I definitely think that there's more work to be done. And we have, sorry, lastly, as I just said, we have some collaborators who are healers, who are also are leaders and healers with healers, and who will tell you that there are healers that one should be working with and healers that you should not be working with, because as you know, one of the difficulties historically in medicine in Africa is that certain healers have been, because of mistrust and things like that, have been asking people to stop taking their medications and things like that. And so we're trying to improve that by having a better collaboration with our healers. And I think it is helpful if you go to that relationship with mutual respect and saying to the healers that you're working with that we don't know everything there is to know as biomedical practitioners, and therefore let's see how we can collaborate in order to improve the lives of people with mental illness.
Thank you very much, Bonga. I would like to take this opportunity now to I'm going to invite each of the panelists to say something before we start winding up. But I think it's very important for me to foreground this by saying this afternoon has been extremely enlightening to many of us. For the participants who are listening in or watching from across the continent, the questions that have been raised, and there are many, will be sent out to the panelists, and the responses that the panelists give will be shared, because people registered using the emails that you registered with. We will share the responses from the panelists. So any questions, keep sending, and then you have the contacts of the Brain and Mind Institute. You could still reach out to us if you have any more questions, and we will channel them to those that can address them. The Brain and Mind Institute also holds regular webinars of this nature, and some blended events where we have in-person and virtual participants. And one interesting one that might address Claudia's question about bringing the old people and the young people together. We had a forum that addressed fathers' mental health. And there were fathers and grandfathers who attended, and there were young people who attended, and the interaction was mind-blowing, where people discovered that people think different things about them. So young people discovered what the older people think about them when they behave the way they do. And the older people discovered what the interactions with the young people mean to the young people. So I think it is useful to have forums like those. Victor, what message do you want the listeners today to take home? Just one pithy message that people will say, this is what I'm taking home from Victor.
I think it's that innovation is local rather than digital. That's one thing for me. Is most times we look west and north for solutions, but most times the solutions are in our neighbor's house or in the communities where we live.
Absolutely, absolutely. Thank you. Innovation is local. I would like to hear now from Florence. What message do people take home from you from this webinar?
From this webinar, I too have learned a lot. And but the key takeaway message, I think for myself and for everybody, is to have a clear understanding of what our individual roles are. There's a role for government, there's a role for civil society, there's a role for academics, and there's a role for people with lived experience. So are we all playing our role? I think sometimes everybody points the finger to government and says, we need a change, we need this, but what is it that each of us have as a role to play? I think let's look into that and take and play our role in order to move all these excellent resolutions and recommendations forward.
Thank you, Florence. Let's start where we are. Start from where we are and from what we can do. So that's a powerful message. And then I would like Bonga, key takeaway message from today.
Yeah, thank you very much for inviting me to this panel. I really think for me, in terms of researchers on our continent, the key takeaway message is that we have so much innovation in Africa. We have so much to learn from our, as Dixon very aptly put it, the wisdom that we have on this continent. And so, yeah, let's keep doing work, using methods that are proper, that are scientific, but infuse them with Africa so that we can indeed be able to contribute and perhaps shine on the global stage. Thank you.
Brilliant. Thank you. Thank you very much, Bonga. And now I come back to you, Dixon. What message do we take home from this pre-launch event for the Lancet Commission?
Thank you. My message is really from the grandmothers, what I've picked up from the grandmothers about culture, which is very important because one of the challenges we face in Africa is internalized racism. And I just want to share what I've picked up over the years from grandmothers about culture, and that is there is no culture that is superior to another culture. When we actually take time to immerse ourselves in any culture, there's always something profound to be learned. Thank you.
Brilliant. Thank you very much. This, it foregrounds how we should be doing mental health, how we should be doing psychiatry, that we should be doing from the perspective of the person coming to us with distress and understanding their culture, understanding the environment, and then using that to identify resources in that culture and in that environment to help them to get better. It's a way more sustainable method than trying to impose anything external on people with distress. Thank you very much. And as I close, then I want to thank everybody who has participated, the panelists, the participants online, and I want to turn it over to Zul to make his closing remarks. Thank you, and thank you very much. Zul.
Thank you very much. Thank you especially to Lakoya and all the panelists for such an exciting and stimulating sharing of information and learnings that we are going to walk away from here. Of course, all provocated by the commission with the Lancet. I think that one of the things that I think that I'm walking away from this session is really to say how much richness there is in what we can learn from our own cultures. And I'm reminded of the adage that when it comes to mental illness, all countries are developing countries, really. So I think that as far as the playing ground goes in terms of contributions and innovations and how we can move things forward, I think what we do here in Africa is going to be very profound and will influence a lot of what happens in other countries. And we didn't get much of a chance to talk about the biological side of the equation. We have focused very much on the psychosocial determinants, which are extremely important. But in essence, I think that as we close the gaps, we also need to close the genetic gap because a lot of the information that we are influenced by comes from North America and Europe. And I like to remind people that the origins of everybody is Africa. And so we need to learn and value what we have. And I'm really very impressed with all the richness that we have that we still need to explore. But I would just like to thank the panelists and the participants to have engaged in this dialogue. And just to remind you that there'll be a follow-up on the 10th of November, which will be another part of the launch of the commission.